session. Welcome to you.
अथातो Hridrogapratishedham व्याख्यास्यामः यथोवाचपदं धन्वन्तरिः. Next is about the Hridroga. Now, whether Hridroga is related to only the cardiac disorders or any diseases of the chest, that would be the question mark. Probably, Sushruta might not have differentiated a cardiac pathology and the other chest pathologies to the same extent as we do it now with all the investigations. But majority of the cardiac disorders also could be considered as the Hridroga. That could be a better view than simply minimizing the Hridroga only to the so-called cardiac disorders as we look at it. But there could be an impairment of the cardiac functions even otherwise, and hence probably when Sushruta says Hridroga, it could be even certain of the extracardiac pathologies which also can present with the symptoms related to the cardiac conditions might have been considered as a Hridroga. Now anyway, we will go with more detail later on. वेघाघात उष्ण रूक्ष अन्यैः अतिमात्रोपसेवितैः विरुद्ध अध्यक्षण अजीर्णैः असात्मैश्चापि भोजनैः दूषयित्वा रसं दोषाः विगुणाः हृदयं गताः कुर्वन्ति हृदये बाधां हृद्रोगं त्वं प्रत्यक्षते. Due to the lifestyle disorders, lifestyle factors like suppression of the physical urges and consumption of food which is not suitable, or excess of the food being consumed, result in abnormality of the lipid metabolism and then so-called the hyperlipidemia, maybe we go into that level, or those food which is incompatible, which can produce cytokine flux in the body, or asatmia which produces hypersensitivity to the body, which is not acceptable, which results in the rasa. Rasa dhatu is the moving part of the blood. So components of this maybe which we call as a plasma component, which results in abnormality of the flow to the heart and flow to the hridaya, and that produces a badhas, discomfort in the heart, hridaya, that is considered as a Hridroga. चतुर्विधस्थदोषैः सात्क्रमिभिश्च पृथक् पृथक् लक्षणं तस्य वक्ष्यामि चिकित्सितम् अनन्तरं. The clinical features, the Hridroga are Vataja, Pittaja, Kaphaja and Krimija, and so 4 types, and their treatment and symptoms are mentioned as such. Ayamete Martaje Hridayam Tujyate Tha Nirmatyate Diyate Spotyate Patyate Pija. A condition where the patient would have acute severe pain in the chest, and there could be even palpitation, and the pain could be of different nature, like as if it is a compressed like, or when it is something like rupture like feeling, that kind of a pain is considered as a Hridroga. Now among the what we call as a Hridroga, the major issue which we will always consider would be the coronary syndrome, acute coronary syndrome, which I will come to that part. Acute coronary syndrome is the condition where there is a ischemia to the heart. The blood flow to the heart is affected either due to a clot moving over there, or the vessel getting blocked over, so on and so forth. And either again there could be 2 types, like sudden blockage of the vessels by a clot moving in, or due to the atherosclerosis where the vessels gradually reduce in size and then hence the blood flow is reduced, or any other condition where the oxygen reaching to the heart muscle is lesser than what is really required, and based upon that ischemia, the grades could be of different degrees. Now other than these ischemic pathologies are so-called acute coronary syndrome conditions or coronary syndrome conditions, the other conditions which can produce a acute severe pain in the chest and which may resemble that of the Hridroga, Vataja Hridroga, could be the vascular conditions like aortic dissection, sudden dissection of the aorta, particularly in case of the dissecting aneurysm, where the blood will flow into the mucous space between the mucous membrane and the muscular layer of the vessels, aorta. Or it could also produce due to pulmonary respiratory conditions which tend to produce a severe pleuritic pain, Now that pleuritic pain, where the involvement of the pleura is there and the pain is localized to any area of the chest, which also is a sign of pericarditis. So there is always a clinical overlapping, and which could be produced due to pulmonary embolism, pneumonia, pneumothorax, or pulmonary neoplasm, tumors also. Or a severe chest pain also can occur due to gastrointestinal tract pathology, where either the esophagus may get ruptured as esophageal tear, Mallory-Weiss syndrome, where the esophagus may get ruptured, or esophagitis due to gastric reflux, peptic ulcers, biliary disease. In these conditions, the pain will be of a specific location, usually in the mid-substernal area, and it may not present with the respiratory abnormalities. Then the pain also could be produced due to musculoskeletal pathology like cervical nerve root compressions or costochondritis, fractured rib, where again a detailed clinical examination can make out. A herpes zoster-like condition prior to that, preherpetic neuralgia, also can mimic a acute coronary syndrome condition commonly. But whenever a patient presents with acute chest pain, to suspect like whether it could be a cardiac origin or not, whether it has to be considered as a coronary pathology or not, or like cardiac pain or not, is an important issue. And the lead points would be if the patient is having a pain which is usually described as a compression or squeezing or burning sensation across the pericardium and may radiate to the neck, shoulder, jaw or back or upper abdomen or any of the arms, most frequently left arm, or it could be to the right side also. That would be the nature where it can lead to suspicion of a cardiac pathology. If the same is accompanied with the palpitations or exertional dyspnea, history of exertional dyspnea, which resolves with the pain or rest, or excess of sweating. One important thing, like excess of sweating is very characteristic of a cardiac issue. A patient presenting with the pain in the chest and sweating, you have to suspect that. Or nausea due to vagal stimulation, or decreased exercise tolerance. Along with these clinical symptoms, if there are the signs like hypotension, which indicates ventricular dysfunction due to myocardial ischemia, or myocardial infarction, or acute valvular dysfunction conditions, or it could be hypertension, which may be precipitating factors for the angina due to elevated catecholamine minerals or anxiety, or even it could be due to sympathetic stimulation. Diaphoresis, that's sweating. Pulmonary edema with the other signs of heart failure, like pulmonary edema where the patient would have breathlessness and orthopnea, and there could be even pedal edema rarely. Or if the patient has a vascular disease history like atherosclerosis, or if the jugular venous condition seems to be distended, jugular veins become prominent. If the patient has a cold clammy limbs with the sweating, that could be a typical of cardiogenic shock. And when you auscultate, the heart sound becoming split, like third and fourth heart sounds they are heard, or a systolic murmur related to the dynamic obstruction of the heart due to any sort of that, or rails or crepitations heard over the area. These signs are there in a patient with chest pain. You have to suspect that it could be cardiac pathology. So a patient presenting with the chest pain has to be thoroughly examined clinically, history has to be taken, and then you have to go for the maybe conclusion. Now, the general standard protocol of treating a patient or considering a patient of chest pain which has some symptoms related to the acute coronary syndrome, the guidelines, the universal guidelines are, if you have to have a ECG and maybe the cardiac enzymes study, cardiac enzyme study has to be done, and particularly troponin study is one of the important critical issue. If these investigations like ECG and the troponin rule out the cardiac pathology, then treat accordingly. That would be the usual protocol. If there is a borderline condition like it could be acute coronary syndrome or otherwise, then the usual suggested treatment is aspirin. If the patient is having a definite cardiac pathology, the immediate medical treatment would be aspirin, clopidogrel as an emergency drug, which is usually prescribed. And then if there is a ST elevation, then you will have to go for ST elevation protocol. That's a cardiac catheterization and so on, which is considered to be an acute emergency, and the intensive coronary care unit care has to be done. This is the standard protocol which we need to keep in mind. Now, I don't mean to say that these protocols were followed by Sushruta, but we need to know about it. And simply to say that Hridroga we manage with the same protocol of Vamana, etc., may not be possible in these conditions. Suppose if the patient has a pain which is persisting for a long time, then you have to follow. It may be crossing that level of emergency where you have to have a planned management, then maybe assess thoroughly accordingly. The risk factors, as far as the prediction of the risk factors are concerned, a patient presenting with chest pain, and if the troponin level is high, and one of the most important predicting factor for the mortality, sudden death and maybe short duration death, would be the troponin level. Higher the troponin level, the mortality rate is higher. So discretion, like whether you can manage the patient or whether you have to refer the patient to a specialized hospital. The one of the most important criteria is the troponin level. So troponin level, if it is much higher, then you have to go for a intensive care treatment as such. And another of the issue is arrhythmias. If there is a arrhythmia, that also could be a possible risk of acute sudden death conditions which need to be assessed. So that's about the protocol of assessment of a cardiac pain, which I would consider this as a Vataja Hridroga. Cardiac ischemic pathologies I would consider as a Vataja Hridroga. Cardiac ischemic pathologies can present with the different grades. In the initial stages, it would be typical angina where the pain is related to the exercise. Later on, it could be a myocardial infarction pain where the pain would be constant even during the resting hours. So, probably Vataja Hridroga relates to the coronary syndromes, acute coronary syndromes, as we consider, along with all those possible conditions which can present with acute pain. Probably Sushruta might have considered as a Vataja Hridroga. Again, that a final conclusion may not be possible, because in the present situation, when we assess the condition based upon the investigational tools like ECG and maybe echocardiography, or maybe the hormone, these enzyme studies and so on, which may not be possible in Sushruta, which we do not expect that kind of an approach in Sushruta's period. So probably there might have been some overlapping. Some of the so-called non-cardiac condition might have been considered as Vataja Hridroga by Sushruta. Krishna Usha Daha Chausha Syuh Paitike Hridayaklamah Dhumayana Murchata Sweda Shosho Mukhasacha. Now, patient with the Vataja Hridroga would have burning sensation, thirst, excess of thirst, and there would be discomfort in the chest, and even impaired consciousness can occur, sweating could occur. Now, these signs are clinically seen in case of pericarditis. Typically, in a patient of pericarditis, when the patient presents with the pain in the chest, the typical pain would be more during the inspiration, and when lying flat, the pain increases, or during swallowing, the pain increases, and when the patient moves about, the pain increases in a typical pericarditis. And it may be relieved by leaning forward while seated. Sitting forward, the pain may be relieved. That is what we call as a typical feature of a pleuritic pain, and this also is a characteristic feature in a pericarditis pain. Along with that, the patient would have intermittent fever, dyspnea, tachypnea, or children may present with even abdominal pain. Pericarditis is a accumulation of the fluid around the pericardium, and it could be of again two types categorized as clinically: inflammatory or constrictive. Inflammatory is due to the inflammatory pathology and exudates getting collected over there. Constrictive is due to the fibrinous development, or the same also is categorized. Pericarditis is categorized as a purulent, hemorrhagic, fibrous, or serofibrinous. Purulent is when there is a bacterial infective pathology. Hemorrhagic often occurs due to trauma origin. Fibrinous are usually due to tubercular pathology. These are the usual causes. Then, of course, the causes for the pericarditis could be at times idiopathic, infectious conditions such as viral, bacterial, and tubercular infections, In systemic inflammatory disorders like rheumatoid arthritis, SLE, scleroderma, and rheumatic fever also can present with pericarditis. And pericarditis produced due to RLA, this rheumatoid arthritis or SLE, they can be quite dangerous, risky conditions. Then metabolic condition disorders like renal failure, hypothyroidism, or hypercholesterolemia also can present with pericarditis. Cardiovascular disorders such as myocardial infarction and aortic dissection also can present with the pericarditis. Miscellaneous causes such as neoplasms, many times drug-induced radiation, cardiovascular procedures like catheterization also can be a cause for pericarditis. When a patient presents with that chest pain which is not typical of acute coronary condition, ECG can be quite useful to make out the pericarditis. Pericarditis in the ECG, the ST segment will be very short and virtually no ST segment as such, and there could be a reduced QRS at the wavelength or QRS amplitude in pericarditis. X-rays often show you a typical onion shaped shadow. Echocardiography with ultrasonographic probe can give you a definite evidence of the pericardial effusion. So pericarditis can be better diagnosed with these tools. So anyway, that's about pericarditis, which I would consider as a Pittaja Hridroga most possibly. Again, there can be a bit exceptions over that, and I don't say that the protocols of treatment of Pittaja Hridroga would be enough to manage a patient of pericarditis now. But a patient of pericarditis managed with the other conditions, when we follow with the protocols of Sushruta, the condition may improve. It can be a supplementary treatment. Then Kafaja Hridroga are Gauravam, Kafasamsravo, Aruchihi, Stambho, Agnimardavam, Madhuryam Vichasya, Balasa, Atare Hridi. In the Hridroga due to Kafaja condition, there will be heaviness and the patient would have Kafasamsrava, the discharges maybe transpirative fluid leaking through, and Aruchihi, impaired appetite and anorexia, reduced motility movement, Agnimardavam, reduced digestion capacity, and Madhuryam asesya, taste appreciation may not be normal. And most possibly, again, I don't say that it is essentially the same, but most possibly this condition can be compared to cardiac myopathies. Like again, cardiomyopathy could be categorized as hypertrophic cardiomyopathy, dilated cardiomyopathy, restrictive or arrhythmogenic, or a deposition disorder like amyloid pathology, or stress-induced conditions also are known as a broken heart syndrome. Now, in all the cardiomyopathy, the ventricular muscles would not be able to pump out the blood fully, and one of the common features would be it results in cardiac congestion, ventricular congestion, and hence there would be impaired peripheral circulation, or even the oxygenation in the lungs would be lesser. Hence, there could be a stagnation of the fluid in the lungs, so crepitations in the lungs, or pedal edema. Even in the advanced stages, accumulation of the fluid in the abdomen, ascites, also could be the clinical features of the cardiomyopathy depending upon the condition, and probably this could be considered as a Kafaja Hridroga. In the present day situation, this can be better assessed, accurately assessed, cardiac myopathy can be accurately assessed with the either ECGs or echocardiography is a better tool. Echocardiography can give you exact amount of volume of the pumped out blood, and even an early tendency for a myopathy can be made out with the echocardiography. So echocardiography is a very effective tool to make out the diagnosis. Then comes the Krimija Hridroga. Uktreshaha, Stivanam, Todaha, Shulo, Hulasakasamaha, Aruchihi, Shavanetrutam, Shoshascha Krimija Bhaveta. In the Krimija Hridroga, the patient would have more of salivation, this tendency for spitting as such, pain and palpitation also could occur. Aruchihi, there could be dyspepsia and Shavanetrutam, discoloration, maybe bluish color in the oral area. Now, Krimija Hridroga is really question mark, whether it is really cardiac pathology or not. I would consider this as non-cardiac issues than really the cardiac pathology. Patients who have the chest pain and discomfort in the chest due to gastrointestinal tract pathologies might be considered as a Krimija Hridroga as such. Some of the translated textbooks consider Krimija Hridroga as a rheumatic pathology, but the clinical symptoms of the Krimja Hridroga mentioned in the text Samhita do not resemble that of the Krimja Hridroga. So that's a point of argument. So we'll not go into that part of the argument. We'll just consider this as a possible non-cardiac conditions presented in the chest pain as a Krimja Hridroga. That's what I would consider. Open for all the discussions further. Brahmaklamo sadashosho jneyah tesham upadravaha krimijatinam shleshmikanam te yemataha. The complications, these would be like giddiness or even maybe catechic changes, like they could be the complications of the Krimija Hridroga, and Kaphaja Vyadhis could occur. Now, as far as the principles of the treatment mentioned by Susula, again, whether the same protocols have to be followed in a patient with the acute coronary syndrome or other cardiac pathologies now is a question mark. But what I would say is, if at all a patient has been stabilized with the same probable diagnosis like acute coronary syndrome or pericarditis or congestive cardiac failure, and if that condition, the treatment patient's condition is supplemented with the protocols of the Susula statement, mostly the patient would have some significant improvement. So I will consider this as a supplementary treatment than really the mainstream treatment for the cardiac pathology. Anyway, now that's again open for all that debate. You will keep that apart. When you read about Sushuddha directly, in case of Vataja Hridroga, the treatment suggested is Vatopasuste Hridaye Vamayet Snigdhamataram Vipanja Mulakwathena Sasneha Lavanenatu Pippali Yela Vacha Hingu Yavabhasmani Saindhavam Savarcharam Athoshunti Majamodam Sundam Paladhanyamla Kaulatha Dhari Madhya Asavadivihi Payet Vishuddhanta Snehena Niramanava. The main protocol of the treatment suggested for Vataja Hridroga is Vamana, and the Vamana has to be done with the Dashamulakwata, with Sasneha Lavana has to be given, Pippali also has to be added for the Kwata, and the patient has, after that, the patient may have to be supported with the Dathi Madhya Asava, which after the Vamana. भोजेच्च जीर्णशाल्यनं जांगलैः सगृह्यरिसैः वातग्नसिद्धं तैलं च दद्यात् बस्तिं प्रमाणतः. After the Vamana and the patient's Agni Sandukshana is done with the gradual adding Shalyana and Jangala Mansarasa etc. And then once the patient has become stabilized, Basti is suggested. And Vatagna Dravya Siddha Basti. That's the standard protocol of the treatment of Vataja Hridroga. In Pittaja Hridroga, Sriparni Madhuka Kshaudra Sita Utpala Jalehi Vamet Pittopasuste Hridaye Sevet Madhurishridam Gridam Kashayam Shaudistan Pitta Jvara Vinashanana. In Pittaja Hridroga also Vamana is suggested, and for the Vamana Kwata given would be Pitta Hridravya like Sriparni Madhuka etc. And the patient has given Ghrita Kashaya, which are mentioned in Pitta Jvara Chikitsa. तृप्तस्य च रसैः मुख्यैः मधुरैः सघृतैः विषग सक्षुद्रं वितरेत् बस्तो तैलं मधुकसाधितं. Then after the patient has become stabilized after the Vamana, then and Agni Sandukshana is done, then Madhura Dravya Sadhita Ghrita has to be given in the form of Basti. Then in case of Kaphaja Vyadhi, Vaja Nimba Kashayabhyam Vantam Hridi Kaphatmake Churnam Payet Uttam Vataje Bhujayechatam Phaladim Atha Mustadim Triparam Vapipenraha Shama Trivut Kalkayitam Ghusam Vapivirechanam Bala Tailehi Vidadhyacha Bastim Bastimshardaha. In case of Kaphaja Hridroga, the Tikta Kashaya Rasa Dravyas are to be used for the Vamana, and after the Vamana, Mustadi Kapha Dravya have to be given, Shama Trivut Kalkayitam Ghusam has to be given, or even Virechana also has to be done with the Bala Tail. Krimi Hridroginam Snigdham Bhojayet Pishita Odanam Dadnaja Palalopetam Treham Paschat Virecheta Sugandhivi Salavanehi Yogai Sa Adaji Sharkarihi Vedanga Gadham Dhanyam Payeta Piarantaram Hridayastha Palantievum Adhastad Krimiam Rudam Yavanam Vitarechasya Savidankam Athaparam. In the Krimi Hridroga, the patient has to be given Pishitodana, non-vegetarian food has to be given with the curds and other fleshy substances for 3 days, and then the virechana has to be done. The concept is, by doing this, giving non-vegetarian food, the krimis are so-called organisms, with suspected organisms, will migrate from the hridaya to the gastrointestinal tract, and they can be expelled out with the virechana. And this is the concept as such. Now, to have a objective proof of this kind of a phenomena is not possible in the current situation, so we will take it as such. Then the patient also has to be given the Sugandha Dravya, Lavana Yoga, and Vidanga with Dhanyamla also has to be given after the Virechana. And the whole concept is the Hridaya Sthaha Padanti Evam, the krimis in the Hridaya would be expelled out. Then after that, patient has to be given Yavana, food with the Yava. With this, the Hridroga chapter is completed. It is Sushruta Samhitayam Uttaratantrantravite Kayachikitsa Hridrogapratishedha Nama Panchamodhyaya Trichatvarimshodhyaya, comparatively short chapter. So we will conclude today. If there are any questions, we will try to answer, and then right, there are no questions, so we will conclude bit early today.